We are really excited to welcome Alex Bendersky today as our next guest. Alex is a expert physical therapist, both from a clinical and research perspective, but also as one of the premier experts and professionals when it comes to digital health and physical therapy and the broader MSK space in particular. Alex is a leader on the digital health side, but also has experience with value-based care models and in home-based physical therapy. So we're really excited to welcome Alex onto our podcast to start sharing his knowledge and expertise that he's learned over the years and what he's really looking forward to with the transition of value-based care models into more digital models for MSK going forward. So Alex, really great to have you and super excited to have you on and to learn from you. My first question for you is, I just tell me a little bit about your background as a physical therapist and how you got involved with digital health.
Yeah, awesome. Thanks. So I'm a dinosaur PT. I've been a PT for over 23 years. So I was the first ever class to graduate with a doctorate in physical therapy. And so I did the traditional Grove hierarchy, like the fellowship training and all the extra letters. And then I got into the health tech space by using like VR in a complex pain management patient care that I was involved in. And so from there, there was an interest in creating a digital front for a company I was working with. So creating a digital front door, going into the risk stratification process using the risk stratification tools, and then understanding that it really is a continuum, right? So getting into a hybrid solutions, into the extension models, and then obviously there's the emergence of RTM systems. So I've kind of jumped between organizations, went from a very large national provider to a more of a regional provider with 100 sites and a direct to employer business side, to an exclusively at home physical therapy provider, to a digital startup in digital health and biomarker recovery, to now I'm a consultant. So I work with multiple companies trying to help them scale and trying to help them introduce a product and a process into traditional clinical workflows. So I think digital health is where it's at. And you and I have spoken about this before, but there is no escaping, no avoiding extension of clinical services into the digital ecosystem. But again, we just have to define it better, right? And hopefully, this is one of the good ways for us to do it.
When you first started, what was the thought around? And I know VR is a little different than what you're working on now, but what was the thought from your peers in the industry in physical therapy and rehab medicine about the role of digital health or even VR in the space?
And so, allied health is an incredibly antiquated process and product, right? Most of our deliverables and most of the patient care uh, origins have not changed much in the last 50 years. So it's still very much a hands-on, face-to-face, in-person, brick-and-mortar process. So when we started experimenting with telehealth solutions, even before COVID, it was a way for us to provide these niche specialty products across state lines. So our interest was in complex regional pain syndrome management. And so there weren't enough providers in the state. So we really looked into these telehealth solutions. How do we extend and triage some of this care to the digital resources? So initially it was just a face-to-face conversation, and the VR was a supplement to a solution, right? Exploring that as a product. We identified a niche, a business niche, where like the company I was working with had two businesses, a traditional face-to-face brick and mortar side, but they also offered musculoskeletal solutions to directly to employers. So they had DTE process. And so this DTE process had a migratory employee workforce. So how do you then provide the musculoskeletal care to a trucker who's on the road 4 or 5 days a week, right? So that's where we started thinking not just a telehealth, but also these asynchronous solutions and hybrid solutions, where if you are available, then you get in-person care, and if you're not available, you extend it into the digital ecosystem. And our biggest constraint there was actually having systems we can rely on. So we looked for partnerships. We looked into building it, which was well, cost prohibitive. And then we finally found a European partner that was doing it already in Brazil and in South Africa. And so we're able to bring their product and optimize it for US healthcare system. That was, I think, the winning combination at that time. But then again, that was like 5 years ago. So
At that time, 5 years ago, if you polled 10 of your colleagues in physical therapy, maybe not in the companies you're working at, but just at large, how many would have predicted where digital PT, digital MSK would have ended up going in the following 5, 6 years? Like, what was the reaction back then from the physical therapist, the rank and file physical therapist of is this possible? And what do you think the reaction is now to a typical cohort of rank and file physical therapists on this digital movement?
Yeah, it's an excellent question. I think 5 years ago, 10 years ago, and now we're still arrogant. We still laugh off these digital only products and processes. So they're like, we laugh at them until they get a $4.5 billion valuation, and then we don't laugh at them anymore. So I think there's a couple of things that like arrogance gets you nowhere, and brick and mortar and traditional leaders, the stakeholders in the traditional space, right? They've been seeing a traditional ecosystem as the only system that's worth investing into. So there's been very little push of extending traditional system into a hybrid space. Same goes for a digital only ecosystem, right? There's been some efforts by these companies that are now publicly traded to create in-person presence, but they've all failed because they never really optimize the essence of these ecosystem of these processes where in person has their value, digital has its own value. But I think both are governed by very unique set of incentives that I think are much more financial driven than qualitatively patient care driven, and that is the primary constraint. So I don't think anyone on a traditional side, even now in 2025, sees the vast opportunity and potential of how they can maximize and capitalize on the marketplace by actually having a digital, like a stable digital product out there under your own umbrella, under your own label. And same goes in reverse, right? So
Yeah, and so when you look at, let's say, large physical like Acme large physical therapy practice, right? Brick and mortar clinics all over the area, national, whatever. There is a fundamental difference between offering telehealth and digital health, right? So telehealth, and I'm happy to hear your take on it. To me, telehealth is okay. Instead of doing this encounter in life, real life, I'm going to do it with a telehealth encounter. But it's the same thing where we're going to do our exercises, do our session, do our intake, and I'm going to build the codes that I do. Whereas digital health to me encompasses telehealth, but also encompasses this kind of more education, exercise library. And, you know, when we look at a big physical therapy practice, right, they can do telehealth very easily. You just do a Zoom or a FaceTime, but it's harder to adopt a digital health program. So how do you reconcile that difference on, or what should that hybrid model look like if you want if that Acme physical therapy practice is going to take advantage of digital health? Is it just telehealth, or is that enough, or where's the opportunity?
no, not at all, right? So I think that like the first step is for the Acme Physical Therapy to recognize that there is a skill economics and then there is expertise economics, and we need to transition from skill economics, where these are my skills, these are the things that I know how to do, to the fact that I'm a musculoskeletal expert in these specific domains, these specific diagnoses, and so my expertise can be outsourced into the digital ecosystem, both like. Telehealth is part of it, asynchronous exercise performance, progress tracking, and all of the above, right? So we like, and that emanates from I think more of a dogmatic view of each encounter being an episode-based encounter, and you and I both understand that a lot of these musculoskeletal problems tend to be defined by trajectories, right? Like they're ongoing problems that will resurface 2 or 3 times a year, that will create a clinical need 2 or 3 times a year. So being the source of truth as a musculoskeletal provider uh, doesn't require you to have a brick and mortar site. You can still offer your expertise remotely by having enough digital content where somebody can manage it asynchronously, right? You can stratify risk. Low risk can be outsourced to the digital only product. A moderate risk individual may choose to encounter a traditional model before they go into the digital model. And then obviously there's a high risk individuals that tend to be like that, the Pareto rule that the 80% of consumption happens from 20% of patients. So that 80% of consumers that are overutilizing traditional healthcare services like need to be on a digital or hybrid system, which continues to provide them the source of truth, the motivation, the expertise that they're looking for, but not through this cost prohibitive in-person model, right? So that's
Yeah.
that's my view. So like that's yeah.
And on our journey on the Protera side, we've met many physical therapy leaders, and there is a camp that says you have to quote get your hands on the patient to do proper physical therapy. And I know you shake your head because I'm the same way. I would say that COVID has normalized the telehealth approach because before COVID, it was rare that I booked a patient for surgery without some sort of like in-person assessment. But like it's not only myself, it's actually much more common now to go right to surgery through telehealth encounters, and then you confirm everything on the day of surgery, but you save a lot of time. People that like we have people that drive 3-4 hours, right, for a very clearly surgical problem. Have you seen that group of physical therapists, that proportion that believe in you must have hands on? Is that changing, or is that still largely the same proportion? In the population of therapists.
I think the unfortunate truth here is that like the hands-on must be hands-on is a like the old guard dogmatic view from clinicians that have poor understanding of these new digital processes, right? Like they just don't, if you don't understand something, you're not going to want to utilize it. And so the clinicians that have best understanding and appreciation of how to best use these resources are also the clinicians with limited power and limited capacity to integrate these resources into a business model. And the individuals that are governing these business models are the individuals that have poor understanding. So that creates that tension point. The ones that believe in a hands-on model, like potentially received their degree 20, 30, 40 years ago, maybe they're as old as me, and they see that same double down, like just touch a patient so that they're happy. The ones that know, understand, like you've also like obviously met the cohort of clinicians that see it, understand it, value it, but they don't have enough pool in a professional sense to integrate that. Like they may be low-level managers, they may be just practitioners, or they may be startup clinicians, right? Like so they have their startup, but they don't have enough bandwidth, enough voltage to actually express their views. So like I think it's a common tension point, but it's very hard to penetrate. Like it's and later on, maybe I'll use an example. Just there was a APTA Future Rehab conference, and you would think that future rehab would be at least digitally infiltrated, right? Most of the patients, most of the participants, like had questions about a legacy products that had nothing to do with digital care. And then when you had digital leaders and leaders in the digital and health tech space, they actually got very little attention from the audience because there's just like how do I make more money by creating these pseudo digital processes like these RTM systems that really don't extend care, but help me get extra $80 per patient per month, versus how do I extend care and actually extend my expertise so that these patients can receive value from our encounter without me actually being in the room. So yeah.
You touched on a couple things. I think one thing from the patient perspective, we have a lot of research, and the research too, that the likelihood of an intervention working, whether it's, in this case, physical therapy, is does the patient believe it's going to work, right? So there are patients who say, "Oh, I tried PT and it didn't work, so now I need surgery." And you say, "Well, how many sessions did you do?" I said, "I had 2 sessions." Well, that's not try PT, right? But if you tell the patient you have a high likelihood of getting better from this if you are compliant with physical therapy, then say, okay, now you did the whole program. So I think how we position this, if a physical therapist says no, you have to have hands on, or of course you can have digital only, that is going to influence things. And the second thing is, you know, obviously I have my own bias, right, from our side of things, but there's a lot of digital companies that call themselves digital PT companies that there's no physical therapy. There's no evaluation, there's no history, there's no treatment, and there's no synchronous care. It's like a phone call, and then now you're on a pathway for low back pain. That is, and I'd love to hear your take on it from a marketing perspective on how companies are doing this, but you're not a digital PT company if you're not doing evaluation, treatment, documentation, and then reassessments or follow up. And so I'd love to hear your thought on that because we see it a lot. And it's just blatantly wrong to say that if you're not doing it. So
Yeah,
yeah,
so
what consists digital PT? Let's start there. What
exactly
what
like
what is consistent?
even a larger question, right? What is physical therapy in general? I think that we have a unique uh I guess, privilege of being one of the few healthcare disciplines that don't have a well-aligned and a well-defined characteristic. There's physical therapy as a discipline, and there's physical therapy as a process, and there's physical therapy as a deliverable, right? And all are called physical therapy, except there's little agreement to what constitutes physical therapy as an industry. So there is physical therapy, and there's physical therapist with a set of skills and expertise to deliver it. And then there is a process, so like the rehab process. A physical therapist therapist who practices on top of their license understands the complexity of a human experience and understands that like that biopsychosocial model of care delivery. Also understands the mitigation of risk based on patient presentation and is able then to deliver optimal care based on available resources. So if your resources are in person, then that's the care you deliver. If you don't have the resources, or if the patient has exhausted those resources, then you have digital ecosystem and anything in between. With that in mind, I think like when somebody is referred for physical therapy, that I don't think it has a single source of truth because physical therapy, as in go do this to see if you can alleviate some of your symptoms, right? There's very a vast difference in physical therapy as a process for symptom management and system allocation to symptom allocation to physical therapy as a process for load management for gradual progression of tissue specific recovery that is specific to your diagnosis. And those are two different domains, right? Somebody who has a high irritability process will get physical therapy and then they feel better. And they're like, yay, physical therapy really helped me. Versus, oh no, I'm still irritable and I still flare up all the time. Yay, physical therapy didn't help me. But that's not physical therapy. That just you had a like poor experience or you had wrong expectation to what this process was supposed to entail. Someone who is a physical therapist who delivers care on top of the license will educate the patient that like your persistent condition requires ongoing care that may need in-person care, may need digital care, may need a combination of both of the above, but it really is an ongoing process that will require you to participate in some form, some event, right? And exercise care is one part, one domain of physical therapy. You have to provide proper conditioning, especially if you can objectify the level of deconditioning. Education and expectation management is another part, like actually understanding where the patient is coming from. And understanding complexity is the third part, understanding, again, the involvement of all of these systems, the behavioral system, social systems, the financial systems into that, how we consume healthcare. So I guess that's my very long answer to your question is that there's like companies that advertise themselves as physical therapy, like especially in the digital only space, they're not physical therapy companies, they're HR companies. They're able to fill a void in these self-insured employers, which is 50% of the country, needing to provide MSK coverage to satisfy a federal need, right? Which they do. They say we have a digital physical therapy product that patients can engage in, and all we have to pay is $895 a year per user per year, right? Which like for them it's a 75% saving from their traditional musculoskeletal spend, except that most patients that engage in these pseudo physical therapy processes still wind up engaging in a traditional physical therapy model. So it's actually most of these employers pay double and triple what they would have paid because now they're paying for this pseudo PT and then they're paying for traditional PT and something in between. And then there's obviously all the other erroneous costs that individuals incur when they don't even pursue PT, but they fall through these low value care models. So,
If you're enjoying this content and want to get more involved with our value based specialty care education and movement, click on the link below to sign up for our newsletter and stay posted with all of our updated events and both web based and in person get togethers. It's a simple Pareto principle, right? So I'm sitting here with you today. If I'm trying to lose a few pounds. If I gain 10 pounds, guess what happens? My back pain starts getting worse. So if I see an ad for a digital solution and it comes across my desk, I'll use it, but I may not even need it, right? And so what you're doing is you're marketing folks the 80% that drive 20% of the cost, where, and I think again, this is where our bias is. If you make a clinical solution, you can, dial into those. You get some of the people who have low grade pain, but really people who are struggling, who have failed surgery, failed injections, failed physical therapy, and they're looking for something different. And so I think the point of focusing on marketing and HR to drive your revenue is it lends itself to trying to get as many people as possible rather than getting the right person in the program.
yeah, right product for the right customer, right? Like
Yeah.
it's that if you're going to use Pareto principle, I just spent $250 on running shoes, and I'm like a world's worst runner, where I'm slow and my form is crap. But it was the right advertisement and the right
Yeah.
marketing is like so I
Yeah.
fell for it, right? It's but to which point, right? Like then like sooner or later, the same person is going to engage in a digital process, and they're going to leave saying that it really didn't work. Like I didn't like it. I didn't like the experience. I didn't like the fact that it felt impersonal. I didn't feel like my questions were answered, right? At the same time, I think that the same employers that are willing to pay $900 for these digital pseudo physical therapy products, they might as well pay that same $900 for a product that has validity, that adheres to best practices, that adheres to evidence-based and clinical practice guidelines, and at least you know that the portal of entry, right, the default portal of entry is going to be risk concordant, it's going to be treatment concordant, it's going to be evidence-based, and that's like something that is not happening now because the same HR department that is trying to save money really doesn't care. They just want to fill the void, right? Like they're jamming it. But I do think that there's a vast difference, like in a spectrum from low quality to high quality, and they're just choosing to go after the cheapest option, not the best option. So
Where I think, and not to belabor the point, but if you're a health plan, you're offering a solution, to your employers, but you're not using it yourself on your own lives, I think that tells you everything. Because the health plans have the data. They know what works, what doesn't work, and they're not going to do some but I think that on the other hand, though, there is a difficulty in accessing physical therapy. And it'll get to my next question, which I'll ask you, but we know there are a lot of places where even if you're in a well-staffed health system, the wait time can be 4 to 6 weeks. We know that in private practice with physical therapy, there's pressure to double, triple, quadruple book patients because, quite frankly, and once you look at the reimbursement for physical therapy, it's not viable for a one-to-one model, right? So where digital, let's say you're doing telehealth PT only, you may not be able to double, triple book, but you're doing one patient at a time, so it's less revenue per hour, but it's also less overhead. You don't have to pay a building, cleaning services, room change, all that stuff, because you can do it. So I think that you know clinical robustness aside, at least getting something to people that they otherwise don't have access to. And also because the other part that's kind of crazy is that physical therapy is open 9 to 5 Monday through Friday. That's what people are working, right? So I think the need for digital is important. My question for you is you've done work in home PT. What are your thoughts on who should get home PT? What are the limitations of home PT? Because you're not in a facility, right? You don't have all the machines. What's the role for home PT in particularly in value-based care, I think, if we use that lens?
yeah, I'm an advocate of home PT because again, it improves access and accessibility to services, and these are skilled services. So I was a director of clinical interventions for this national provider with 3,000 therapists, right? And so that the construction of the company was brilliant. You use an Uber model where somebody can request a service, and if there is a service provider available within a 50-mile radius, and if it works with their schedule, they will come to your house and deliver care. Uh, the only failure here is that without standardizing that deliverable, you have a very large, poorly controlled product, which ultimately results in the dissatisfaction and disenfranchisement, especially of the payer. The, so you, without control, without standardization, you don't know what you're providing. So I think the model itself is viable. We also again have to define what does it mean to be at home. Like you have like I can get a haircut going to a salon, I can get a haircut going to somebody's house, and I can get a haircut by getting a stylist to come to my house. That all comes with availability of those resources, and all comes with what I'm willing to pay for. It's like if I want somebody to come to my house and they're a therapist, the price difference here is like these therapists get $75 per visit. The company gets another $25 overhead cost, and then they're able to build insurance, the traditional 4 or 5 CPU units that are based on traditional fee-for-service model. You're right, it's not sustainable. You're right that a lot of PTs unfortunately succumb to an economic pressure of uh, booking multiple patients at the same time, of not really providing evidence-based practice care, and by poorly standardizing the deliverables. But that's in our industry. In return, I think consumers need to demand more. Like I think it's up to a consumer to actually understand what should be entailed. I think that there's a much better structure and much better understanding of what to expect when you consult an orthopedic surgeon, right? So like if my knee hurts and I have a path dependent solution that last time my knee hurt, I saw an orthopedic surgeon, I received this intervention, I felt better. So I'm gonna continue to consume healthcare through that default model, then like it's functional. But the default model starts to fail when you either don't have available resources or the resources are cost prohibitive, right? So then like what becomes the default model? So if you're gonna enter a like in-person care like through a at-home care, you have to stratify the specific population that are best benefit from it. Either population that has mobility deficits, so they need in-home care, or population that is looking for convenience and then they can receive home care, and both can be financially incentivized to like either by paying a premium for the service or by getting a reduced quality of care. In regards to like the type of sources you need, like it's again like it's okay to have access to these advanced equipment, but I'm a purist in physical therapy sense where your low tolerance and your threshold is directly dependent on your ability in the moment. And so, yeah, if you gain 20 pounds, it probably is correlated to deconditioning and other confining factors, right? So it's not just the weight gain, it's the weight gain plus sedentarism plus immobility plus some of the other constraints. So, yeah,
Yeah.
yes, it'll get a long answer to it. So,
Well, no, and you kind of the home-based model, right? If I think of my archetypal patient, it would be somebody, let's say after a joint replacement, spine surgery, they can't really move much, they can't get in a car, they don't have access to services. But and and I don't know how home-based PT works from a financial model. I don't do it, so I don't know how it works. I know there's a vibrant home nursing industry, but you almost are in a situation where you can't double up patients. You can do one-to-one. It's in person and you have overhead. It may not be a building of overhead, but now you have to pay somebody to drive around to go to a location as many as 50 miles away. And what are you doing for that driving time? It might be the therapist just eats it, but it does make it hard to scale unless there's some sort of premium on the pricing where either the agency is getting paid more than regular fee for service rates, or there's some sort of value based arrangement where there's a shared savings model. But I don't know if home PT is, you can tell me what your thoughts are. Is home PT value proposal really about value-based care cost savings or improving access to fee-for-service care for individuals? Which of the two is it?
again, it could be both. So working with the same company, right? So you look at the risk-based care provision. So you have a payer that identifies the specific a patient cohort that is at risk for either increased downstream utilization or worse clinical outcomes. Once you identify these individuals based on their demographic, based on their location, based on the procedure, based on poly morbidity, right? Like that's where you then provide in-home care because it reduces the likelihood of falling through the cracks, right? Like not accessing care, and increases the likelihood of this care being standardized because you can control the delivery of care through this in-home solution. So you can provide value-based care in home and with much higher probability of being validated care. At the same time, you can play devil's advocate and say you don't always need to be one to one with the patient. Like there's parts of every process, right? Like so, like in like I'm obviously I'm not a surgeon, I'm not a physician, but there's parts of your care like as a skilled surgeon that is specific to having this skill set of being a surgeon, but then there's also parts that are less skilled, right? Like making an incision or closing the incision or like doing all of the post-op triage, right? Do you really need to be an orthopedic surgeon to ask somebody how they're feeling 24 hours after surgery, right? Now, and same goes with physical therapy. There's parts of a clinical skill set to identify these at-risk patients, right? So someone who has an irritable, persistent pain condition needs a higher level psychological care than even physiological care, right? You need reassurance. You need to map a recovery plane that is easier to understand. That therapist, if you understand that patient, like your skill set is in education, not in your ability to touch a patient, whether you do it at home or through a digital medium or anything in between. An in-home visit will pretty much allow you to identify this, right? Because I do think that there is something about like that, like especially value-based process, that there's patient-centeredness, there's therapeutic alliance that is easier to gain when you're in somebody's house. It's easier to gain when you're speaking face to face. But is it necessary for at-risk patients? Absolutely. For everyone else, no, it's a luxury. It's like it's a value add, right? Like so you can add that as a part. Like you go to a restaurant and you can get your burger and your fries, but if you want your milkshake, then like that's like it will cost you extra. So that I think we need to understand that, and we need to understand that process, that physical therapy as a skilled process. Like there's parts that are expert driven, and the rest of it is skill driven. And anything that's skill driven can be supplemented, complemented, or outsourced. Anything that's expertise driven needs to be delivered by a physical therapist. Because that's where the expertise comes from. Like that's where your training comes from, and that's I think that large spectrum of professionalism within the industry. So.
You brought up the variability of quality of care with physical therapists. I will say physical therapy, more than any other field in MSK, has been doing things to at least help, at least my opinion is help with quality, because they actually measure patient reported outcome measures, right? It's really the PTs that have been measuring those scores. How, and us in orthopedics only now are starting to measure them because CMS has forced us, which we've obviously known was coming down the pike. Where, when you look at prom measurement PT, what has it done to help improve that quality? How do you think, are we using it? I'm sure we're not using it to our highest, potential, but like, how are we using it now in physical therapy, and how can we be better about it in physical therapy? And of course, the same goes to MSK, but in physical therapy perspective.
I think patient-reported outcomes and patient-reported outcome measures are an absolute necessity in any part of healthcare, like whether it's MSK or not. But the way to use it, I think it completes the entire picture, right? You want the individual's narrative about the pain impact or that like disability impact on their daily function. So these tools are sensitive to change, and tracking change and objectifying change can only be done through these PROs, because besides patient's subjective narrative, besides your objective examination, besides some of these objective measures, outcome measures are complete the entire picture, right? So it's a diagram with like, and that's a piece of that diagram that is an absolute necessity. What we can do better is we can do better in terms of standardizing the application of these outcome measures. That we need a process that provides outcome measures that are appropriate for that specific diagnosis, that are interpreted at the right time, and that has the right pacing. And then we need to believe in them. I think that like you fall into the same sunk cost heuristic, that like when outcome measure shows a positive return, we say, yeah, that's because I'm such a good therapist. And when the outcome measure shows a plateau, then you say, well, it's just not accurately depicting
Yeah.
like this, right? So we kind of need to get away from that like basic cognitive fallacy of not believing something because it doesn't confirm our worldview, but actually trusting it. So, but I think outcome measures are an absolute necessity for healthcare and especially for musculoskeletal care.
you know, Value-based organizations are risk-bearing entities. There's different buckets, right? You have your employers, the self-funded employers. You've got your health plans that are fully insured. They're, Obamacare, Medicare Advantage, et cetera. Then you've got the provider side, right? Some of them, ignore for a second the ones that are fully at risk, like the Chen Meds, the Oak Streets, and so forth. But a typical value-based organization has some fee-for-service care, some value-based care, some upside only, some upside downside, some, hodgepodge, right? Which is most health systems. They're not typically using digital health for MSK, but what do they need to do to capitalize on the value opportunity around digital care when it
I
comes to
think
MSK?
yeah, like there's been a number of really good studies, and like so if you look into the different systems using point of entry, right, the default point of entry, and using physical therapy as a primary care point of entry into the MSK space, and then track downstream healthcare utilization and healthcare spend for the next 24 months, you just see a significant reduction in global healthcare spend. So like, and the three domains you can look into economic domain, like just PT as a primary source of entry results in lower financial cost, like to the system, to the payer. The second part is reduction in these iatrogenic effects, right? Like so PT as a primary core point of entry reduces iatrogenesis, including reduced opioid intake, reduced polymorbidity, or reduced sedentarism. So these iatrogenic effects from these musculoskeletal problems can be resolved with PT being a primary point of entry. The third point, I think that can have a positive impact is clinical outcomes, because like we're in the United States, so we need to get away from these binary thinking that physical therapy or traditional medical care. It could be physical therapy and traditional medical care. It could be physical therapy and behavioral care followed by traditional medical care. All of the above. Like we are the ones that are making this cake, right? And if you choose to make cake better by putting salt first, that's your poison, right? Like we have the capacity to change that. But like obviously I'm incredibly biased because I'm a physical therapist, so I'm going to tell you from my worldview that PT first, it makes sense. But you have University of Utah system, health system, that's used it and has really positive impact and effects that they've studied over like long-term effects. You have I think Balin Medical System in Wisconsin that has used it as a point of entry with positive impact on all those three domains. So like the proof is in the pudding, right? Like the proof is in data that we have available to us. So like how do we use it? Like you run experiments, you A/B test it. You if you already are delivering care, like if you're Chen Med and you're delivering care, you A/B test. You do like a PT triage followed by everyone else, or you do everyone else followed by PT triage and see what comes next.
You bring up Bellin, which is really interesting because our one of our podcasts, which is about to come out, is with Dr. Joe Cookstorf from Bellin. He's one of the quality leads, physical therapist, and we spend a lot of the time talking about the embedded PT model. And primary care has embedded mental health for quite a while. It's actually pretty common to have an embedded mental health specialist because 50% of the country has some sort of need for a mental health specialist. Same with MSK, right? And if you think about the unnecessary referrals, right? My mom's a primary care doctor. Throughout residency and beyond, I would always get questions from her saying, "Hey, what do I do with this person with a hand pain or this foot pain?" Or because they don't have the bandwidth or experience to treat them. But what's mind blowing to me is the logic of an embedded physical therapist in primary care. Here you have almost everybody. Think about the Medicare population. Who doesn't have back pain or knee pain or hip pain? You now have physical therapists who can say, you know what, at the very least, this is not a problem. Let's get them in PT. We'll set them up. We'll take care of them. You're done, because you would have ended up there anyway after a MRI, another injection, or an orthopedic evaluation. Or, hey, this is actually a problem. They need to go to ortho right away. So you can actually triage upstream right away and cut down, whether that's an in-person embedded PT or some sort of asynchronous digital analog. But how come more systems are not doing it? Because it seems so common sense from a value-based perspective.
I think that's just a business churn, right? Like the systems are looking into that next quarter deliverables. Very few are looking into deliverables across like 3 to 5 years, partially because of how we set up these systems, that they're just not designed to manage these individuals for more than 2 or 3 years. They know that they're going to turn up somewhere else. And partially because these systems don't have the capacity, the bandwidth to manage these individuals beyond a certain threshold, temporal threshold. Uh, but there's two important economic phenomena that we can discuss, right? Like, so that the musculoskeletal impact on absenteeism, right? Like, on inability to return to work or perform your activities of daily living. But then there's also presenteeism, right? Like, so there's people that are essentially walking wounded. Like the impact, the economic impact of walking wounded is extensive. Like, and you look at all the studies, global studies, like there's Lancet that's done really good job working it up, is that the economic impact is probably a 10-time multiplier for these individuals with a musculoskeletal complaint that are just living with it. They're not pursuing care, but they're not being as productive. They're not being both in the workplace. They're not being as productive in their daily life, and that musculoskeletal problem has a direct impact on every point of entry for them, and they're being either undermanaged, or they're like, once they get into the system, they get into the system when it's too far gone, when the problem has evolved to the point where it's either irreversible or the problem is really expensive to treat. So that presenteeism versus absenteeism is a good way to like look through these. So how do we integrate physical therapy? I think that's we have to have a baseline source of truth to what physical therapy should look like for these systems, and we also have to have a baseline source of truth to that through clinical care guidelines that you will follow, like best practices that you will follow that are aligning with best available evidence, right? The evidence evolves and evidence changes, but we need to at least have a bare minimum basement source of truth that we can adhere to. And if we do that, then every system should be using some form of musculoskeletal triage, even if that means that like this is your 10% discount to a gym. Like, why don't you just try to go to the gym twice a week, right? Like, that's going to be your solution. Or you have a little bit of a psychological impact, and you're just a little bit higher on the catastrophization scale. So maybe like these are behavioral health services that will offer to you for you to overcome some of these problems. So yeah.
One other thing along with the presenteeism is, guess what happens to your mental health when your back pain gets better, right? So, like our data, it's about 30 to 35% improvement, depression, anxiety scores in folks at large. So, the if you went to an employer or health plan and said, okay, what's the economic benefit of a 30% improvement on your mental health? It's going to be pretty profound, right? I mean, everything follows that. And so I think that MSK care, I mean, it is also value-based care in general, right? It's very primary care heavy, and our systems have really focused on primary care measures, screening rates, vaccine rates, medication adherence rates. They're all important, but the money's being spent on specialty care, right? That's what people are really like. The back pain is going to be much more front and center than a hypothetical risk for a vaccination to a lot of people. And so I think that as we start getting more, and this is what you're doing, this is what we're doing, trying to get more exposure from an education perspective into specialty care, I think it's going to change because that's where the dollars are being spent. I mean, at the end of the day, most of them are being spent on the specialty side.
Yeah, there are two ways to look at the like present teams of impact, right? Like a cognitive and emotional pain impact. And cognitive is how you feel about your pain, and an emotional impact is how your pain makes you feel. And both are impactful, right? So cognitive and emotional involvement with any pain specific condition, like, and there's also something to consider, like for us clinicians, right? That there's a over threshold pain experience and a sub threshold pain experience. Like there's a point of nociception that is not pain specific to you and I, right? Like, it's not discomfort, but it's still impactful because it's that sub threshold nociception, like where there's a nociceptive output but not pain, but you're still being impacted by it. Like that, I think that's a good one to recognize that. Yeah, like maybe you're not feeling well because you're just not feeling well, and there's a resolution for it, right? And it's the entire complexity of the system and the dependencies of these systems on each other that we need to be humble and understand that I'm just a part of the solution. You are part of the solution. Behavioral health is a part of the solution. But again, if you're going to circle back to the digital health, why not reduce the friction point of accessing these healthcare solutions by creating a default mode of entry through the digital ecosystem? Like, it's available, it's present, and then create clear ways of onboarding and offboarding these solutions, um, but by just reimbursing them, by creating incentives to have these solutions as a default point of entry.
You know, when you talk about access, what's kind of, so we, in the early days of Proterra, we were trying to get access as a fee for service provider. And we said, why don't we just go fee for service and just blanket whatever markets we're in? We couldn't get a network, right? So at the health plan level, I think one challenge I have, and it's, the health plans are facing all kinds of their own economic pressures, but it would take a year or longer to get in network as a basic fee for service provider, right? And so we couldn't even, when we talk about access issues, we couldn't even help that because the health plan's taking so long to credential. And that's just there's a lot of reasons to contribute to that. And I'm not saying in a pejorative way, but everyone's got their own, bottlenecks, but it's hard. And so even getting that fee for service care where most people access healthcare, right? We've been talking about digital health. You mentioned earlier this whole conversation. My guess is that 99.9% of all MSK care is through brick and mortar still. Right. I mean, like
Yeah.
even though we're all half of us have our insurance through our employer, if you have a bad back, you wake up with sciatica, your leg is numb, you're not going to go log on to your HR benefit site. You're going to go find a clinician or an ER, urgent care.
Mhm.
But I think so. So getting that digital health in the traditional brick and mortar access, like you're saying, is so important. Looking ahead, the next 5 years, 10 years, where do you think we're going to go with terms of digital MSK access for these fee for service brick and mortar channels or value based channels? Where do you think we're going to be? How much adoption do you think we're going to have, or what it's going to look like?
It's a wonderful question. I wish I knew, right? Like, then I would invest heavily into it and retire in 5 or 10 years. Um, I think that there is an fortunate or unfortunate dependency on what the next administration is going to look like. Current administration, I think, has done some things right. I think kill the clipboard is a right movement, right? Like it's digitizing and digitalizing deliverables is the right step because you are creating a financial incentive for organizations to create digital solutions. But there needs to be more, and it all depends where, like in 3 years, we have new administration that either chooses to support it or it's going to be somehow fringe event and they choose to kill it and then pivot 180 degrees to something else. I think the trend is in the right direction. So I think in 5 years, you wouldn't have a choice to access healthcare through the digital ecosystem because you're also going to have the consumers age into the healthcare system. The ones that are best understand digital ecosystem are the ones that are also not using it because they're healthy or healthy-ish. The ones that are using healthcare systems are the ones that didn't grow up with digital ecosystem. So, like, oh, the same kids and adults now that are spending hours on TikTok are going to spend hours on their digital health providers on their phones, right? Like, because they know it, they understand it, they like it, and so it's convenient for them. So I guess in 10 years, I would say we're going to age into these systems being viable. In 5 years, next administration will tell. It depends on what the political sources are like. That's
Yeah,
my yeah.
and so let's take it the opposite direction. So, you have had a very kind of I'd say a deep expertise in the space, and I know we're all just getting started, right? Like it doesn't really. We started doing digital PT in 2012. We were way too early. That was probably one of the timing issues, um, but the field is still in its infancy. As you look back on your career, what are you most proud of, and what are you most excited about for the next steps for you?
Yeah, it's like it's amazing to think how quickly that like 22 years have gone, right? Like I'm excited about recognizing how little I actually know. Like I'm Eric, I'm learning every day. Like and so like I'm excited about the number of resources that are available to me now to learn. So it's just been a truly a profound net positive to be humbled by smart individuals like yourself and to learn from you, to learn from others. Now, I'm also humbled to have the opportunity to have a voice. Like, so, like, um, I think I reflect on the last 23 years and I understand how little I actually knew before and I understand how little I know now. But I also understand that all of my prior errors have somehow benefited my awareness and knowledge of where I am now. um, I think it's like I'm a student of like reading and learning because I think there's like I don't believe knowledge is created, knowledge is extracted. Like and so we extract this knowledge through experiences, through conversations, through exposure. So the more conversations like this we can have, the more experiences we can have, the smarter we'll be. And so like knock on wood, I'm still healthy enough to probably have another 20 years of productivity. And I still have a kid just out of college and a kid that's about to go to college. So then I'll just have to keep working for the next 40 years to pay for college. So
Well, if you miss the younger days, I've got a 6 and 4 year old. You can come by and duke it out with us at dinner time and try to get through that with us. That's actually harder than any clinical work I've done. And I think that for everyone listening, Alex has on his social media highlights research articles weekly, if not almost daily, and is able to kind of distill the most pertinent literature into the points that we need to know about. So I think I would encourage you all to follow Alex and benefit from that knowledge like I have. I think I'm excited about the next steps. You've done a tremendous job educating. I've benefited from that, and I hope others are. And I hope we can bring awareness to the role of specialty care, especially MSK, in value-based care, because it's something that affects all of us. And it's unlike many things, unfortunately, like it's hard to prevent cancer. It's hard to prevent some chronic conditions. MSK is modifiable. Like if we just do a better job with delivering value-based care, we improve health and lower costs. And so that's kind of my thought on our combined mission. So I want to thank you for joining, Alex, and I think this was super beneficial to everyone, and I certainly learned a lot as well.
Eric and I appreciate the opportunity and thank you for all you do.